The patient with a sickle cell disease that you may come across in your intensive care unit. I have no conflict of interest. Sickle cell disease is most frequent monogenetic disease in the world, and not just in France, not just because of the overseas territories, but it's also the most current disease in the Île-de-France region. If you look at these graphs, they're quite telling. In the US, the rate of patients go up regularly between 2004 2010. Here are admissions in the Île-de-France for vaso-occlusive crisis, and you see here that in the acute chest syndrome, migrations are connected to this. You see what's happening in North America and in Europe, areas where the prevalence of the disease has increased significantly after the 80s. The molecular basis of the disease is quite simple. It's a mutation on a beta chain of globine gluonval, which is going to modify hemoglobin, and the main feature will be that it polymerizes in deoxygenation conditions, and this is going to modify these erythrocytes, and they're going to adopt this falciform aspect. They will be less prone to distortion, and the disease is therefore connected to occlusion of the capillaries, which are post-capillary venules with little oxygen, and the occlusion, the vascular occlusion, is going to result in clinical signs, both acute and chronic. In trying to compile all these in different clinical phenotypes, we have, first of all, a series of complications directly connected to vasoocclusion on the venular pole of these micro vessels. Hyperviscosity is going to play a key role. In this category, we're going to find the traditional occlusive crisis, but also the acute chest syndrome, and we have, on the other hand, things which are more connected to the endothelial distension. The hemolysis, the chronic hemolysis phenomenon, by releasing free hemoglobin, is going to recapture NO, make it less available, and therefore this functional deficit is going to result in chronic organ impairment, such as priapism, leg ulcers, strokes, and the like. When you look at complications experienced by these patients, you find clusters with complications that are either connected to endothelial dysfunctioning or to vasoocclusion and hyperviscosity. Specifically in intensive care, a recent study of the Tenon Hospital team shown that the acute chest syndrome is the cause number 1 for admission in the ICU unit department. Here we have a series in South Africa. Usually it goes with organ, it goes together with organ complications. This can result in acute pulmonary heart, or even dysfunction or multiple organ failure, which is going to encompass the liver, kidney with congestion. There are other causes such as neurological, but there are more rare or pure hematological complications. The Tenon team looked at predictors of, showed clear signs of that can provide for a complicated prognosis. We can use these signs either as a score of ICU admission. You see that it's basically similar to the traditional one we may use, such as SAPS-2. And we are going to focus on the acute chest syndrome because it's the most common complication that will come across. This term was suggested by Charras in 1979 because he saw that in a majority of the patients with syndromes related or looking like pneumonia, no germs were evident. So he concluded from that that there was another phenomenon involved besides infection that could account for the symptoms, and came up with a hypothesis that it was a pulmonary infarct through a sort of pulmonary vasoocclusion, and he coined the term acute chest syndrome. Today it's not just limited to pulmonary infarct, but it groups together all of the complications of the acute chest syndrome connected to sickle cell anemia. Now, the risk factors are basically age, young age, a peak between the ages of 2 and 5, then it comes down, but we don't know whether it might not be at least partly connected to the reduction in the mortality of these patients, who will have less complications. A genotype in the incidence of the acute chest syndrome is important, with SS genotype and S beta 0. Fetal hemoglobin plays a protective role because it's protection against falciformation, and as it goes up here, we have a reduction of the ACS rate on the right-hand side, total hemoglobin, and the leukocyte count in the blood increases the risk of ACS because it's related to hyperviscosity, and it is a complication which is connected and which is linked to hyperviscosity. ACS may trigger sickle cell anemia in a patient who up until now had no symptoms. At least half of the patients with an acute chest syndrome have been admitted to the hospital for another reason. They have triggering factors such as postpartum pregnancy, surgery, and the occlusive syndrome, and environmental factors as well. We've known for a while that there's a seasonal impact, particularly in the winter time, and particularly young children. There's a peak November and December, and the climate plays a role, the weather. Here, in this recent study, there's a clear role of the average temperature. As it goes up, the risk of having to go to the ICU comes down. So cold weather increases the risks of vasoocclusion, and progressive decrease of temperature from one day to the next will also result in an increase in the risk of being hospitalized. And wind comes on top of cold because it's the experienced temperature which matters, is probably what triggers vasoocclusion in these patients. And as the speed of wind goes up, we have an increase in the hospitalization rate of these patients. So pollution also plays a role here, with an adverse effect of fine particles, but it is quite surprising to see that CO2 plays a protective role, and it therefore has a protective role on the vascular endothelium. There might be something to work on for future research in that. So diagnostic criteria, there is no consensus, but you require at least a clinical sign and an X-ray infiltrate. Clinical sign can be coughing, temperature, pain, dyspnea, etc. According to the age, there's going to be different signs involved, pain and dyspnea much more for adults and children, probably also connect to the fact that children have less, for children it's more difficult to communicate. The infiltrator, we require at least a segmentary consolidation and no atelectasis. So you must have an X-ray, even if the patient is in bed, to make sure you have that. But you get away with it basically because the involvement is in the lower lobes in the adults, at least at 95% of the cases. So you can exclude ACS if the lower lobes are preserved. Whereas here we have both lobes being involved. And pleural effusion in 25% of the cases. Here with the CT scan, we have shown the basal character of these lesions. The lower lobes are the ones that are really involved. We have very little around glass, and atelectasis is rare. This basal predomination is quite clear in adults. So this is confirmed in this study, but less so in children before the age of 2. No basal predominance of lesions. If you require consolidation, if you want consolidation to be at least segmentary, it means that you're going to need more transfusions as opposed to patients without the segmentary consolidation. In an X-ray in bed can give you a differential diagnosis. Here, for instance, we have a true consolidation. The problem is the specificity that is really low, and it's connected to the difficulty of having an X-ray made when the patient is bedridden. Opacities are difficult to interpret, and in the CT scan here, no real consolidation. That would be a sign for an ACS. Now, several actors are going to be involved in this physiopathology, 4 mainly. First of all, fatty or greasy embolism, which has been described years ago. Mechanism is simple. ACS usually is preceded by a vaso-occlusive crisis. These free fatty acids are going to play, of course, a major role. We're going to have digestive and neurological involvement, impairment as well. Godot in 1996 showed that the right-hand side the patient with an acute ACS have much more superimus macrophage show as opposed to the sickle cell or non-sickle cell disease control. Here we see clearly the macrophages in 60% of sickle cell disease patients. This positive coloring in tracheobronchial secretions is clear. If we do washing in these patients, 40–60% will have a positive coloring, and with these patients with greasy embolism, the cellular count of the BL is much higher than the other group, with a significant increase of polynuclears and lymphocytes, so it's much more inflammatory type of disease here. Bronchoalveolar washing is less frequent now, but you can have an induced expectoration test here looking for the greasy embolism. It's a good prognosis. here in this study is quite satisfactory. And we look at clinical signs in these patients. The ones with a greasy embolism have more frequent vaso-occlusive crises because of the release of lipids in the blood flow, and neurological signs compared to the other patients. More inflammation here. So traditionally, this expectoration is of a golden yellow hue. It was thought for a long time that it's coloring, that it's greases that colors the expectoration. That is not the case. In this study by Daniel Lepos and Contou, we see that it's probably the color of the plasma and the seriousness of the lesion, with protein levels and LDH levels that are almost similar to what we have in the bronchoalveolar washing and in the plasma. And then there's a second protagonist that's been evidenced more recently, which is the thrombosis, the pulmonary arterial thrombosis. Here it was shown that 17% of ACS patients have a thrombus in a major pulmonary elastic major vein artery, associated to an increase in platelets, and particularly in people that have platelet rates higher than the ones that have no thrombosis, and peaks are higher as well. When we look at the density of these thrombi, we see that it's probably of a chloric nature, not greasy, because we're above 30 and outside of the traditional density area for greasy thrombi. And these thrombi have a topography that is similar to pulmonary condensations with a basal predominance, like pulmonary condensations. But what is significant here is that in this series there was no deep venous thrombosis for these patients. That was evidenced, whereas in the traditional thrombosis, at least 1/3 of patients associate to their pulmonary thrombosis deficiency a thrombosis, which suggests that this exists for major arteries, but is also to be found in micro veins. So this is found in a lot of patients at the autopsy, and it was difficult to interpret, of course, because we know that agonic anoxia can result in stasis in a pulmonary flow that can be mistaken. But almost 50% of patients had thrombosis in their pulmonary vessels, and it is also associated to the presence of a greasy embolism, but however less frequent in these autopsy series. On top of these two protagonists, we have a third one, infection. In most sickle cell disease patients, the ACS looks like pneumonia, and given the diagnosis criteria, you can't make a differential diagnosis from pneumonia. So infection parameters are entered in the general picture. The effective documentation of these infections is rare. In the best series, we go up to 15–20% at the most. Very often you can't find the germ. And when it is documented, it's not traditional germs. This is the distribution of the germs. In children, it's mostly viruses. And the incidence will decrease with age, and adults will have chlamydia, mycoplasma, the atypical germs or pyogenes that do not represent most of the germs that we usually find in those patients. And the last protagonist is pain. Coastal infarcts that can result in hypoventilation with atelectasis that can be complicated with consolidation. These patients have a lot of morphine, consciousness disorders, etc. So all this is added on, but at least half of the patients, or mostly adults, no cause is found that can be a specific cause for triggering the ACS. So we still have a lot of work to do on this syndrome. The ACS biology includes an inflammatory syndrome. Everything goes up, leukocytes, hemoglobin comes down, hypoxemia, platelets vary compared to the baseline, hemoglobin is down. However, bigger increase of leukocytes during ACS, which is normal. Complications: mechanical ventilation about 10% of the patients, death in about 5% of the patients. There's probably a center-related effect because in centers or hospitals used to having these patients, there's less transfusion because when you have less patients coming to you, then you don't really know what to do. So here, mortality is not limited to the hospital setting, but it continues once the patient has left the hospital. And back prognosis factor is the radiological extension of lesions, quite normal, and thrombopenia is a poor prognosis, as well as cardiac disorders. Here you see pulmonary pressure goes up during ACS, then becomes normal, and this acute figure here, it has a lesser, it has a worse prognosis. Is connected to hemolysis and vaso-occlusion phenomena. Now, this has nothing to do with chronic HTP in 6% of these patients, acute pulmonary hypertension, but when you look at the number of episodes, there is nothing of that is really significant. It is mostly associated to venous ulcers, and again we have two different phenotypes involved, the endothelial phenomena and thrombosis and vaso-occlusion on the other hand, favoring the onset of ACS. How to prevent it? Hydroxyurea long course is good, and sensitive spirometry will also decrease the risk of an ACS. Pre-op transfusion of patients that are going to undergo surgery decreases ACS rate in post-op. You can hydrate, provide painkillers, oxygen, NIV, transfusion, steroids, INO, antibiotics, anticoagulants. In the case of pulmonary thrombosis, morphine plays a major role in terms of painkillers, PCA titration. A study has shown that INS are not interesting here, but this can also be relevant for the ACS. Here, Marielle Fartouk has shown that there is no real efficiency of non-invasive ventilation, probably connected to how patients were selected. Transfusion is the general tool that is used to treat ACS currently, but there are risks associated. Number one, hyperviscosity, so hemoglobin should not too high in the patients that you selected, and hemolysis also, I talked about it. Indications, clinical criticality, and we don't yet know whether simple transfusion is better than exsanguinal transfusion. Usually we do the latter, but in this non-randomized cohort there was no real difference. So alloimmunization, you should be very careful. It can concern up to 50% of patients in some series, basically connected to the fact that these patients have racial antigen differences. Donors usually are European patients, and this can result in delayed hemolysis post-transfusion phase. Here, a patient transfused 3 days before, ACS, multifactorial anemia, and also reticulocytopenia associated. You should absolutely avoid any new transfusion. It is the main strategy, APO if necessary, and many forms of immunomodulations, but at the experimental stage I will not go into the details. Anemia according to reticulocytes, to classify the origin of anemia in these patients, to make a difference between all these various aspects. Antibiotics, less than 20% of the events are documented, but we have to give antibiotic therapy because there's an infection risk, and we must absolutely give antibiotic therapy. There might be a role of PCT to detect invasive infection in these patients. It doesn't work very well, however. Corticosteroids will enable you to bring or reduce the criticality of the ACS, but there might be then a risk of having to re-hospitalize this patient for a vaso-occlusive crisis. And a recent study completed on the interest of nitrogen monoxide, apparently there is a benefit for the most critically ill patients. And if you have ADRS and ACS, major pulmonary vascular dysfunction is the main thing you should look for, and you should protect the pulmonary vascular system. And finally, it's a complex syndrome in terms of its physiopathology. It can evolve quickly towards respiratory distress, ADRS, and may result in multi-organ deficiency. If you intubate, you have to monitor the heart, of course, with the echography. And I thank you very much for your attention. The